one. What is the difference between a mammogram and a breast ultrasound? So what is a mammogram? A mammogram, for most of us over 40 who've had one already, knows that we use radiation to create images that tells us what the breast looks like and what's inside the breast. Ultrasound, on the other hand, uses sound waves to create those images. So the difference is one uses radiation, one uses sound waves. A lot of people are concerned with the radiation portion in mammography, but I have to tell you, the machines that we use are very sophisticated. I see the comment that a mammogram's a torture. We do have to compress. We compress because we care. It's our motto. And I'll explain to you why the compression is necessary. But the mammogram, while it uses radiation, is still very sophisticated machinery. We use 3D mammography these days. The 3D portion has a 2D aspect, and the tomographic image portion, what we call 3D, is just basically slices of tissue that we look at in the breast, which gives us more details. So why do we need to do a mammogram if we can just do an ultrasound? A lot of patients ask that question. Some of them vehemently said, I don't want a mammogram. Let's just do an ultrasound. Rarely will we ever do that. And I'll explain right now why. So a mammogram is the gold standard for detecting breast cancer. It is the gold standard because 90% of breast cancers are found on a mammogram. For example, if you have microcalcifications in your breast, we can't see that on an ultrasound. We can't even see it on an MRI. We can only see it on a mammogram. So let's say you have a cluster of microcalcifications starting to develop in the breast. If you say, okay, and insist that I just want to have an ultrasound, and you go years just having an ultrasound, that cluster of microcalcification will not show up on an ultrasound until 5 to 10 years later. When it's advanced, they can see it on the ultrasound. It's now a full-blown mass, and it's harder to treat and usually not a favorable outcome. So that's why the mammogram remains the gold standard for detecting breast cancer. All right, the question of who needs a breast ultrasound and why, right? So a breast ultrasound is determined, those who need it is determined after you've had the mammogram. So we can't determine if you need a breast ultrasound unless you've had a mammogram. Why? Because the breast ultrasound tells us the category of your breast tissue. So our breast tissue is divided into 4 categories. You have extremely dense, you have heterogeneously dense, you have what we call scattered fibroglandular, that's a 3rd category, and the 4th is fatty breast tissue. So the first, extremely dense, mostly women with 75% of their breast tissue. If it's dense, you need an ultrasound. If it's considered dense, you need an ultrasound. And the state of Connecticut have by law since Jody Rells, yes, when she was governor, because she, most of you know, she had breast cancer. She had bilateral mastectomy from breast cancer. So she put it into law that if you have dense breast, then it should be stated to you in writing. Your primary care physician should know about this, and you should by right have an ultrasound. So I know Connecticut is one of a few states who have that on the books as a law, that if you have dense breast, you're entitled to an ultrasound. So 75% of your breast tissue is dense, you can get an ultrasound. If you have what we call scattered fibroglandular tissue or fatty tissue, you do not need an ultrasound. And I've done ultrasounds on fatty breast tissue. It's very difficult. You can't really see anything. Remember, we're working with sound waves, and if we can't pick up anything with sound waves in fatty tissue, there's nothing to see, and we can see so plainly on a mammogram what's inside your breast tissue that you really don't benefit from. The only thing you'll be doing is throwing away money on a breast ultrasound if you have fatty breast tissue. So that answers the question of who needs a breast ultrasound and why. So when we talk about why, we talked about the fact that you have dense breasts. So with dense breasts, think about it as a cloudy day. We know the sun is underneath the clouds, but you can't really see it because of the clouds. So a dense breast acts in the same way. It's so dense, it's kind of like a cloud. We don't know what's lying underneath it until we use that sound wave to penetrate the tissue. Then we can see more of what's underneath that dense breast tissue. And that's where the ultrasound comes in handy. It's really a complementary tool to the mammogram. It doesn't replace it. It just complements it for certain women. And how do you determine who needs an ultrasound? So that fourth question, going back to the third, we use what we call a BI-RADS system in mammography. BI-RADS is an acronym that means Breast Imaging and Reporting Data System. It's used for the all the various organizations, the ACR, the MQSA, which is a monitor for all things breast imaging. That's a standard that's used by radiologists to determine the category of your breast. What do I mean by that? Let's say you have a mammogram. If after you've had your mammogram, everything is normal, everything's fine, there's nothing seen, you have nice, boring breasts, nothing going on, we will assign you a BI-RADS, and it will be in the letter that goes to your doctor, a BI-RADS of BI-RADS 1. It means it's normal, we found nothing, you're good to go, you're nice and clean, BI-RADS 1. But before the BI-RADS 1, let's say you came in for a mammogram, we saw something, we saw asymmetric density, or we saw a mass or a nodule, or we saw, what else can we find in that tissue? Any number of things, mostly asymmetric densities, distortions, architectural distortions, any one of those things. If the doctor says, this is new, we didn't see this last time, we want you to come back for more imaging, we assign you what we call a BI-RADS 0. So that means you need a further follow-up, not a 6-month follow-up. You need to come back now so we can determine so what sort of things can we see that will prompt this BI-RADS 0, like I said before, those scattered asymmetric densities. Asymmetric density can mean any number of things. When we compress your breast tissue, and I know I saw the comment about the mammogram hurt, we compress you because if you have dense breast tissue, you have which is a large combination of dense and some fatty tissue. Every woman will have fatty tissue. That's how your breast is made up of adipose tissue, dense, scattered mammary tissue. That combination, when we're compressing, some of that tissue superimposes, that means it sits on top of each other. It can create these asymmetric densities. And we don't know if this is something it's a cancer forming there, or if it's just overlapping of breast tissue. So we assign you a BI-RADS 0. We want you to come in. We're going to add even more pressure than you got before with smaller paddles. And this is to spread out that tissue, because some women, once they start crying, you need to stop, it's too much. You know, we can't do our hands. We try to explain, we compress because we want to spread out as much breast tissue as possible. But if you cannot stand the compression, chances are sometimes that's why you're called back. There was just not enough compression. That's why I say we compress because we care. We don't want to see you back, because then you get nervous, you start thinking you're dying, when really all you needed was more compression to spread out that tissue. That asymmetric density that's sitting there is 90% of the time it's overlapping breast tissue. All we need to do is add some more compression and you're good to go. But sometimes there are architectural distortions. This is when the tissue looks a little distorted. That's a little bit more troubling, because it more likely might be some speculation, and you're assigned a Barrett 0 because we want to interrogate this more. If we find microcalcifications that are new, microcalcifications, again, like I said, forms 90% of those breast cancers. So there are various different kinds. If they're loose, if there's a microcalcifications are like, think of them as grains of salt, right? If we have a grain of salt here, and then further out we have another grain of salt, we don't usually worry about that. But when we have grains of salt gathered together, let's say we have 4, 5, 6 grains of them that weren't there before, we assign you a Barrett 0, because we want to see what this is that's creating these microcalcifications. So that's your Barrett 0. Anything that we haven't seen before, anything that's new, anything that looks a little disturbing, we assign you a Barrett 0. We need you to come back. We can either, we do spot magnification views, regular spot compression views, or we can do a targeted ultrasound depending on what is seen. If it's a mass, more likely we're going to do a focused ultrasound in that area to determine what this mass is. And we'll get to the ultrasound portion in a while. So the Barretts are Barrett 0. Barrett 1 means you're nice and normal. Barrett 2 also means you're normal. But if you have, like we said, those calcifications, if they're classically benign calcifications, that means we know they're not cancer, they're fine. Maybe they're milk of calcium. Because there's something there, you're not squeaky clean, we give you a Barrett's 2, and you're still good to go. You don't need any follow-up. If you are assigned a Barrett's 3, it means that there's something in the breast. We called you back. We checked it out. Let's say there are microcalcifications that we think were benign. We're not sure. We did some spot magnification views. They don't look worrisome. But we want to make sure, and in order to be sure, we say we're going to follow these up in 6 months. So we assign you a Barrett's 3. Why do we want to follow them up in 6 months? Because if calcifications are going to become unstable, it takes a period of 6 months for us to see that change. That means instead of a cluster of 6 calcifications, if 6 months down the road, you now have 12, that means they're unstable. There's something going on, and we need to biopsy them. Because overwhelmingly, if we can see that the features are classically benign, we don't rush to biopsy. We do a 6-month follow-up if we think they're probably benign. It's rare that after 6 months you come back, they become unstable and warrants a biopsy. That's just so rare. If off the bat we decide that we're not sure what they are, we want to be absolutely sure they are not classically benign, then we say, let's do a stereotactic biopsy and find out what they are, okay? And it's just quicker than having you do a 6-month follow. So those are your Barrett's 3. It means we need a 6-month follow. Sometimes we don't just follow things up with a mammogram or ultrasound. Sometimes we do an MRI. Again, a lot of people want to rush to, let's do an MRI. MRIs, they're very good, but they're very expensive, one, and they have a lot of false positives. It means they pick up things that aren't real, and then you get stressed out and worried for no reason at all. So those are reserved for a very small minority of women with extremely high family risk values, personal risks, and very dense breasts, or women with implants who have a lot going on in their breasts. And then we get to the next category of Barrett's system, which is a Barrett's 4. So if you're assigned a Barrett's 4, it means the doctor feels whatever they see in the breast, whether on mammo or ultrasound, warrants a biopsy. So now you get a Barrett's 4, it's going to say something like suspicious findings, Barrett's 4. We want to biopsy this. Doesn't mean it's going to turn out to be bad. It means that it didn't have features that tells the radiologist that these are definitely benign, or this is definitely benign, this mass is definitely benign, these calcifications are definitely benign. We need to biopsy them because they're indeterminate. That's more the terms they would use. They're indeterminate, so let's give you a Barrett's 4, we're going to biopsy it. If you have been assigned a Barrett's 5 on your mammogram or ultrasound, it means that the radiologist looks at your images and sees something that they think is highly suspicious for a breast cancer. And I truly have never seen a Barrett's 5 that has never come back as a cancer. So if they assign a Barrett's 5, they don't do it lightly. It means there was enough evidence for them to tell you features of this mass or these calcifications or whatever they find is not good and needs to be biopsied. If you, the last Barrett's is a Barrett's 6. If there is a Barrett's 6 assignation, it means that they've already determined you have breast cancer and now you need follow-up. We did the biopsy, it came back positive, so we already know, and in the report it will say proven malignancy, Barrett's 6. So that means they've already proven it's a cancer. It's going to be, your report will be assigned a Barrett's 6, and the next step will be whatever treatments are necessary, lumpectomy, radiation, chemo, whatever the breast surgeon determines is the best next step. So those are the 6 Barrett's assigned. It's almost 7, right? 0 to 6, yeah. So 7 Barrett's assigned through the breast imaging and reporting data systems. And this just kind of helps us determine what your next follow-up. If you're a Barrett's 3 and we need an ultrasound, that's what emphatically it will state that in your report. These are probably benign. You need a follow-up ultrasound in 6 months or a follow-up mammogram, whatever is seen on the, again, on the mammogram or the ultrasound. It depends on what they first found it on, which system they first found the problem on. So those are the Barrett's that will determine what your next follow-up is. And how do we determine who needs an ultrasound? We talked about that, the categories of your breast tissue, if it's dense, if it's fatty, if it's scattered, if it's extremely dense, that will determine if you need an ultrasound. But these cannot be determined just by feeling the breast or a breast self-exam or a clinical breast self-exam. We can only know if your breast is dense if you have a mammogram. A mammogram shows us what your breast tissue looks like. And that's when we'll say, okay, she's heterogeneously dense, she needs an ultrasound, or she's extremely dense, she needs an ultrasound. Those are the only 2 categories of breast tissue that warrants an ultrasound: extremely dense and heterogeneously dense. So again, differences between a mammogram. We stated that the mammogram shows 90% of breast cancers. Most of these are calcifications. So let's talk about the masses that warrants those ultrasound. So that's where the big difference comes in. We can see masses on mammograms, but it's hard for the mammo because it doesn't use the sound waves like ultrasound to determine the features. We can see if they're nice and smooth or round. Sometimes it depends if the breast tissue is so dense that we can't see the borders clearly. That's where the ultrasound helps us out. Someone is saying something. That's where the go ahead, I can't hear you.
there's a answer a couple of questions in.
I couldn't hear. Was someone saying something?
Yes, there's a couple of questions in the chat.
Okay. Do you want me to answer the questions now or wait?
Whichever way you want to do, what's best for you?
All right, let's look at the questions. I didn't really take if the breast bleeds, if the breast bleeds occurs after mammogram, should one be concerned after mammogram? Okay, so I was gonna talk about, and this was more gonna come in with more info on the ultrasound about bleeding of the breast. You don't get a bleed from a mammogram. Your breasts don't bleed because of a mammogram. If you're tagged, how often should you come back? What does tag mean? I'm not sure. If you're called back, if you're tagged, how?
It's Sister Nadine, going back to the first question, I think the person is saying, I mean, the mammogram may not cause bleeding, but what if after they have a mammogram, their breast now is bleeding?
Okay, so bleeding, if you have a bleed from the nipple, I was going to cover this in the ultrasound when I talk about what, okay, so let me just, so I could cover that. Let me talk about the breast ultrasound and the importance of it. So let's talk about masses, right? Like I was saying, when we see masses on a mammogram, we can't determine, in some cases, we can determine if these are simple cysts, or looks like a fibroid adenoma, but that's where the ultrasound comes in handy. That's why it's a complementary tool. So now we use the ultrasound to help determine what some of these masses are. Whenever a woman comes in and says she has bloody nipple discharge, so I'm gonna take that to mean if you have a bleed after a mammogram, generally that means you're talking about a bloody nipple discharge. You have bleeding from the nipple. So a bloody nipple discharge, I know it sounds alarming, but in 90% of the case, if you have a bloody nipple discharge, we can't really see that on a mammogram. We can take pictures of just the nipple, which is painful. So we just take you to ultrasound and scan the nipple. What are we looking for? We're looking for a mass in the milk duct. If you have a mass in your milk duct, that will cause a bloody nipple discharge. A mass in your milk duct is called a papilloma. It's called intraductal papilloma. It's benign. That means it's not cancer. It's just a mass that's in the milk duct, and it's causing blockage. So that's why you bleed. Sometimes breastfeeding women, a lot of them will have that. Duct ectasia is a clogged milk duct for those who are breastfeeding. After a while, if that the milk ducts, everything leads to the ducts in the breast, right? And these ducts, if they become inflamed, if they widen, if the walls kind of narrow, you can get these blockages. And that's what causes the duct ectasia, and the bleeding is if there's a mass in those ducts. It's usually not a cause for concern. The only breast cancer that we know of that causes a bloody nipple discharge is Paget's disease. So if we've ruled out a papilloma, we've ruled out duct ectasia. The only other thing, if there is a mass that is irregular in those ducts, then they're going to want to biopsy to see if you have Paget's disease. Paget's disease is so rare, no one really is ever concerned that a bloody nipple discharge is actually going to be Paget's disease. It's more highly likely it's going to be a papilloma, which is just a benign mass that's in the duct that's causing it to bleed. So that's why you would have a bloody discharge after a mammogram. And I've had women who said they've had bloody nipple discharge. When they come in, they don't have it, or we can't find any evidence. It kind of happens sometimes sporadically, but I've scanned a I've done ultrasound scans and have seen a mass in the duct, and we usually just, sometimes they can follow it up if it's, you know, the first time it's happened. Some women get them often, but in most cases, the radiologist knows this is just a papilloma, and they'll report it as that papilloma that's causing the bloody nipple discharge. Sometimes there's just nothing. It could be an inflammation. Some women get abscesses and they'll get a bleed, but most often a bloody nipple discharge is caused from an intraductal papilloma, which is a mass in the duct, and it's benign. And then there's the ductatasia. For most women who are breastfeeding, gets that clogged milk duct, and it's usually painful. It's kind of cakey around the nipple. You can ice it. Sometimes your doctor may put you on some antibiotics just to clear it up a bit. So it's usually not highly concerning when you have, I know it sounds bad, but trust, it's intraductal papilloma is most likely the culprit for a bloody nipple discharge. What other questions? I know I elaborated.
Yeah, she asked if you're tagged, how often should you come back? And she's saying after a biopsy. If you're tagged, okay, after the biopsy, how often should you return?
That means by tag, you mean if they leave a clip in the breast after a biopsy?
I have no idea. Yes.
Okay, so years ago, we used to, because our radiologists were what I call overzealous. After we do a biopsy and we put a clip in, they might say, let's have you come back 6 months just so we could follow it up. And my question would be like, why? If we've already proven under biopsy that this is benign, what's the point of a 6-month follow-up, right? So they kind of stop doing that for most cases. It's only cases where there are multiple clusters and we only sample one cluster, the other cluster looks similar, and we want to make sure that there are no changes. We've biopsied one cluster, it's benign, but you have so many different clusters of microcalcification. We'll just say, all right, come back in 6 months so we make sure the others look benign and nothing is unstable. But the reason why we do biopsies is to prove that the thing is benign or otherwise, right? If we've proven that it's benign, then there's no need to follow up. There's nothing to follow up. We've gone to the extreme of finding out why you have mass in the breast or why you have microcalcifications in the breast. It's a biopsy proven benign. We just move on. Most cases you come back in 1 year. So depending on where you go, we're in Lower Fairfield County, is aggressive when it comes to breast cancer. I had my first biopsy when I was 35, right? And the standard was that at age 35, you get a baseline mammogram. When you reach age 40, if everything's fine, you don't have a strong family history, you have a mammogram at age 40 every year from that point on. North of Fairfield County, I would say New Haven County, because I worked at Yale, they don't recommend starting mammogram till you're 40. I see so many 30-year-olds with breast cancer. It was a shock to my system when I see how many women are coming in, African-American women in 30, 32, 35 with breast cancer. It was a shock to me. And I'm just wondering if it's because there's some kind of change in what women are doing. I couldn't understand it, but it was just a large number of breast cancers in women under 40, women under 35. It was a couple of weeks ago, I scanned a 32-year-old African-American woman, and she had bilateral breast cancer. It was, I mean, what I saw the left side, I saw the mass in the left side, and there was something on the right that I wasn't sure. I was talking to the other sonographer, and she says, I don't like it, I don't know. And it had showed up on her MRI. And I was like, it's just inconceivable. She should have breast cancer in both breasts. But then her results came back. They biopsied the right side, and she had breast cancer there too. So, you know, sometimes it's not cut and dry. So I see your question about should the radiologist be more skeptical about papilloma? Intraductal papilloma is defined as a benign mass in the ducts. So unless they see something weird about that mass, and we can, in ultrasound, we do 4 different planes. We do an anti-radial, radial, we do a vertical sweep, and transverse. So when I was learning it, I did a lot of radial, where you look at the breast as if it's a clock, and then, or let's say the spokes of a wheel, right? And well, it's the spokes of a wheel, but with a clock. At the very top is 12 o'clock. And then if I'm gonna point to my left breast, so at the very top is 12 o'clock. And if I'm going towards my armpit, I go 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, right? So we look at the breast as a clock. When I do an anti-radial sweep, I'm thinking of the spokes of a bicycle. And so I'm scanning the breast. 1 o'clock, I'm going against the spokes of the wheel. So that's called anti-radial. And then if I see something anti-radial, like a mass, I'm not sure if it's real, I do a radial sweep. So now I'm turning from anti-radial. I'm now moving from going against the spokes to going with the spokes of the wheel. And those 2 planes will tell me if it's real. If I only see something in one plane, it's not real. Chances are it's not real. I have to see it in 2 planes for it to be real. So that's why when we look at masses on an ultrasound, they scan in 2 different planes. It's like golden standard. Some places we're doing a transverse and a vertical sweep. I think they've made it the ACR recommendations is that you do anti-radial and a radial sweep. But let's talk about mass summary, since we're now on the big issue of ultrasound and the difference between it and the mammogram. So mostly ultrasound encompasses a mass. Like we said, ultrasound cannot see microcalcifications. It can see some calcifications, but these are macro calcifications. That means they're large calcifications. I will have some pictures here. Give me one second. I'll show you that in a minute. But it won't show you microcalcifications, and that's why we can't use breast ultrasound to determine most breast cancers. So looking at mass summary, most masses, we go to ultrasound to determine what they are, right? There's the description, oval or circumscribed, tend to be more benign looking masses. If they're irregular, if they're not indistinct or microlobulated, angular, spiculated, then these are more suspicious for breast cancer. So looking at mass summary, we look at how the mass appears. An oval mass, I'll give you an example of that. An oval mass is something like a fibroadenoma. I have a fibroadenoma in my left breast, and it looked like a fibroadenoma, but I did the biopsy and it came out as a fibroadenoma. It's oval shape. So anything we see looking oval shape, more likely is a fibroadenoma. Now, are all fibroadenomas benign? The very definition is that a fibroadenoma is a benign mass. But there's some things that we look at when we ask you about, when we are scanning your breast looking for masses, we ask you some very basic questions. Your age, right? We look at the risk factors for breast cancer. Gender is the biggest, being a woman. Age, being over age 60, is another big factor. So if I have a 75-year-old woman who seems to have a fibroadenoma in her breast, then that's not normal. 75-year-olds should not be developing fibroadenomas. Fibroadenomas is usually in young women who are having their periods, because it's mostly hormonal, right? Teenagers, women in their 20s, women in their 30s, women in their 40s, even early 50s will have fibroadenomas. But a 75-year-old with a fibroadenoma or a mass, an oval mass that looks like a fibroadenoma in her breast, that's a red flag, because that's just not typical, right? So we look at women with different masses in their breast. We look at their age and what could be prompting these masses to develop cysts. Even though cysts are benign, an 80-year-old woman should not be developing a cyst at age 80. So we look at that again. And these are why we would jump to biopsies now. These are because you can have a mass developing in what looks like a fibroadenoma. Not too long ago, a couple of months ago, it was how old was she? 19-year-old. She came in and I was scanning her. This is when I was training, and I see this big mass. It took up like almost all of her breast. And I'm worried. I'm thinking, what is this? And I'm scratching my head. And after we stepped out, the senior ultrasonographer said to her, she said, it looks like a fibroadenoma, but I'm not sure. We did scan her axilla to look at her lymph nodes, and something was funky there. But when the radiologist came in, and she's very good at her job, she declared that it was a fibroadenoma and wanted to do a follow-up, just to prove that's what it is. But she's 19, so the chances that it's a fibroadenoma is very high because of her age, and she's going through hormones. So when we look at masses in the breast, we look at the summary of mass. We take into consideration the age of the patient, what the mass looks like. Let me see if you can see this. So ultrasound is black and white. There's no color in ultrasound, so the images will reflect that. Black and white images may be hard to see, but that's really what an ultrasound is. So I don't know if you see I said ultrasound findings. If you can, I kind of drew this picture. This is what an oval mass look like, and this is more likely what a fibroadenoma will look like. This is microlobulated. Usually benign masses will look microlobulated. They're not worrisome. It's just funky looking. This looks like a lightning bolt. Now, if a mass looks like this, chances are it's a cancer. If it looks like this is what we call irregular shape. If it looks like that, you can see, chances are it's a cancer. The shape, right? We talked about the oval mass before. Shape of it, that's what it will look like this is a real picture of an ultrasound. This is a round mass, and I don't know if you could see here, this one's irregular. You could see the shape of it. This is irregular. This is highly suspicious for a breast cancer. I have echogenicity. What do we mean by echogenicity in breast ultrasound? So breast ultrasound, like I said before, uses sound waves, right? When sound waves hit an object in the breast, that will determine the type of echogenicity it gives off. If it's an object that is solidly benign, it will be hyperechoic. That means the image will appear, this is not a good picture, it will appear lighter. Everything in the breast on an ultrasound is compared to the fat in the breast. We have the fatty, let me just, I think I have, might have a picture. I don't know. Everything in the breast is compared to the fat, right? Sorry about that. I thought I had a picture, but I probably don't. All right, so everything is compared to the fat in the breast. Fat on an ultrasound is a medium gray tone. Anything lighter than that fat is termed as hyperechoic. And if we see a mass that's hyperechoic, chances are it's benign. Now, if it's hypoechoic, that means it's darker than the fat. It has uneven structures within it. It's hypoechoic, it's more suspicious for breast cancer, but not all hypoechoic masses are cancers. You have a hypomass that, like a fibroadenoma, can sometimes have a it's usually termed as a hypoechoic mass, but it's a fibroadenoma because it is oval in shape. So we look at so many features of a mass that will render it benign versus suspicious for malignancy. So if it's anechoic, it's usually benign. It's cysts are anechoic. So a cyst, we call that, it's when I first saw it, it's just like a black hole. That's what I call it on an ultrasound, and I'll show you what that looks like right now. This big black hole. This is what that looks. It's a structure that's filled with fluid, and this big thing on in the breast, it's a simple cyst, right? It's just it's structure filled with fluid, and that's why it's black. Anything black on the ultrasound is fluid filled. It's kind of like your bladder. Your bladder, if someone scans your bladder, it's going to look like this black hole because it's filled with fluid. So this is a simple cyst. And underneath here, do you see that bright area? This is what we call posterior enhancement. So that's a good sign that this is a cyst, because when the sound waves hits this structure, it can't go anywhere. It can't penetrate. So it shadows and it gives you that posterior it's not shadow. It gives you a posterior enhancement. It enhances, it gives us that bright look, which tells us once we come upon this structure that this is more likely 99.9% going to be a cyst, which is benign. Okay, so that's a simple cyst. A complicated cyst. Now you could see the structure. It's black, but it has this little area. It's like a bright dot in it. If this was completely just a simple cyst, it wouldn't have this. It's a complicated cyst. A complicated cyst, again, is benign. It's just that this little thing is called debris. It has some debris in it, and that's why it's not simple anymore, because it has some debris. I did show you, okay. This structure, this is we talk about complex, complicated. This is complex. And you're wondering, well, complicated, complex, isn't it the same? Very different. So the complicated has some debris. This, you can see, has cystic elements because it's black. That means it has fluid in it. But you see these little white things? These are solid masses attached to the walls of this simple cyst, otherwise simple cyst. So it moves from being a simple cyst to a complex solid cyst. This is more suspicious for a breast cancer because it's complex. It doesn't have just debris, it has solid components in it. And you shouldn't have solid components in a simple cyst. That's not good. So that when we look at the ultrasound, these are the things that we look at when it comes to the texture, the shape of masses that we see. I remember it wasn't 2 weeks. No, it was more than it was like 2 months ago. I did it's a young girl too. She was only 39 and she has never had a mammogram. She said she felt a lump. And when I did her mammogram, the first thing that struck me was the amount of calcifications she had in the area that she was feeling a mass. Now, because she feels a mass and I see the calcifications, I already knew she had breast cancer, not because of the mass, but because of the calcifications. Granted, she was 39. If she'd had a mammogram, let's say 5 years before that, so 39, so 4 years before that, 35, those calcifications would have probably looked like tiny little dots that we would have biopsied and would have probably been what we call DCIS, ductal carcinoma in situ. It's like an early stage breast cancer. But now she's presenting with this big giant mass that I can see and feel, and she's loaded with calcifications. Tells me that these calcifications have now formed a mass. We talk about this 5 to 10 years later, those calcifications form that mass. That's how long it takes. That's why it's so important that you have the mammogram and have it early and not just have an ultrasound, because it can be the difference between treating a simple early stage breast cancer and an invasive breast cancer. Big difference. So now she has this massive cancer in her breast. After I did her mammo, we were gonna go do her ultrasound, and in the ultrasound, you could see the mass. You could see that it was what we call taller than wide. Let me show you a picture of a taller than wide. We talk about the fibroadenoma oval. Let me show you that one again. So it's not the fibroadenoma. Oh, 1 second. Let me go first. Here it is. Okay. This is the fibroadenoma. I have something like I said, I had mine looked almost like this, and I had it biopsied. So this is a fibroadenoma. It is, when we measure, we put what we call calipers on. These are just measurements and an ultrasound. We measure that it's wide, right? And it's wider. You can see it's wider than it is tall. So from side to side is the width, from top to bottom is the length. If it's wider than it is tall, chances are it's benign. Okay, now if it is, okay, this one, if it's taller than it is wide, chances are it's a cancer. You could see the difference. This is wider than it is tall. This is taller than it is wide. This is a cancer. This is a fibroadenoma. So anything taller and anything taller than it is wide will give what we call a shadowing. It will shadow behind. So when I'm scanning the breast and I see a mass that like this, that's taller than it is wide, and then it's shadowing, it's giving me shadows instead of an enhancement. So that means there's a dark space going down here. That's not good. I'm trying to see if I have a picture with that shadowing. I don't seem to have any. I might find it. Yeah. Yeah. So that shadowing is not good because it's hitting a solid structure. It can't go anywhere. So it shadows. When you hit a solid structure that has echoes in it, it enhances. So you see this bright area around the mass. That's enhancement. That means this is, it's not a solid mass. It's just fluid filled and it's benign. This, once the echo hits it, it's solid, it shadows, and it's taller than it is wide. So it's a cancer. So those are the things that we look at when we do an ultrasound, because it gives us a lot of information when it comes to masses in the breast. Most are benign, most are general, your general cysts, depending on the age. Again, we see cysts in mostly women who are going through hormonal changes. They're having their periods. So your teenagers, your 20s, 30s, 40s, early 50s will have cysts. Sometimes patients are loaded with cysts. They don't do anything. They can sometimes drain them if they bother you. We call it an aspiration, just going with a needle, take some of the fluid out. And you feel some relief from that. Sometimes if you add some cold compress, that will help. There was a patient who came in, she had an abscess, and we did a biopsy on her, and it was just vials and vials of pus coming out of this patient's breast. And she was a heavy smoker, so she has this abscess, and when you smoke like that, it doesn't help. That was part of because that was one of the questions we asked on the questionnaires. Do you smoke? For how long? So many different questions that gives us pointers as to what we see in the breast when we see it, if it's more likely gonna be benign or something more worrisome. What age did you have a first child? How many children do you have? Do you have children? All questions that actually are part of the whole aspect of determining breast cancer in women, because all of it adds up. Like I said, the big ones are the gender and the age, but the minor ones, again, are having children over a certain age, because most of it relates to, some of it relates to hormonal changes. Women who have periods earlier, well, your body's hormonal changes, and have period later in life, like menopause, going through late menopause, have hormonal changes. Women who, the majority of women who've gotten pregnant and then have a mass in the breast, when we do the ultrasound, it's a cancerous mass because of the changes in the hormones related to pregnancy. It's not very common, but most often when we've seen it, the 36-year-old pregnant for the first time with a mass, it's hormonal based. So those masses usually turn out to be a cancer based on hormonal changes. It's 8:08. Let's go to the questions.
Thank you, Sister Nadine. If you have any questions, you can post them in the chat, or if you prefer, you can just raise your hand and we'll acknowledge you, and then you can ask the question.
Good evening, Sister Nadine. Sister Ingrid here.
Hi, good evening, Sister Ingrid.
I'm really enjoying the program, but I have a quick question. How does breastfeeding relate to the cancer in your breast, and how important is breastfeeding?
So they ask about breastfeeding on the questionnaire because, you know, if you think about the breast, a big part of knowing about the breast is it all, like I said before, leads back to the ducts, and we're talking about milk ducts. All roads in a breast ultrasound leads to the ducts. Let me see, I think I have a picture, and everything kind of develop around ducts. So that's why breastfeeding is important. You get clogged milk duct for women who can't aren't breastfeeding properly. You get that soreness, that cakiness, usually infection because the milk isn't flowing properly because either the duct is blocked or something. It usually don't create breast cancers. Breastfeeding causes ductatasia because of the clogged milk ducts, or you can have a mass in the duct, like we talk about intraductal papilloma. I think breastfeeding is just one of the minor reasons for your risk factors, but they haven't proven convincingly whether you breastfeed or not that is going to contribute to an increase in your breast cancer history or risk. So it's
Thank you, ma'am.
Yeah, you're welcome. Any other questions?
Any other questions? And Sister Nadine, don't worry, I'll be coming to you for my mammogram.
Okay.
Thank you, Arlene. Okay.
Okay,
Sister
Sister
Nadine.
Heather has her hand up. Sister Heather, you can unmute and ask your question. And then Sister Henry, I don't know if you had a question. If you did, then you're next.
Yes, thanks.
Sister Heather, please unmute and go ahead and ask your question.